All right, welcome everybody. How many of you were here for the first seminar that we did? Okay. For those of you that were not here, Kelsey has some, where are those at, Kelsey? Okay, there's some newsletter articles that are all running specific. Tonight we're going to talk about running injuries and prevention, and then management stuff. The next seminar that we have is April 12th. And that we'll have John Sinclair and talk a lot about training principles, nutrition, recovering after racing, things like that. So hope you can make that one. Tonight I will do a couple examples with hopefully somebody here will be game enough to come up and let me test and show some things.
I will.
Okay. All right. One other thing. In these talks, sometimes we'll use some language or words that can be misunderstood. Maybe it's a medical terminology. The best way to go away with good information from something like this is to ask that question on, can you explain what that term means or what that anatomical feature is? Feel free to do that with myself and with Dr. Hecker. Also, really informal. If you want to ask a question, you do not need to wait till the end. We can clarify those things as we go. All right? All right, so today, prevention and management. In running injuries, we're going to talk tonight mostly about the overuse injuries. Acute injuries, I stepped on a rock, rolled my ankle, I pulled my hamstring by tripping or falling. Those are in that acute category. But in the, can you hit the lights for me? In the overuse category, what we're talking about is cumulative micro-trauma over and over again, whether that's a 2-mile runner or a marathon or ultra-distance runner, okay? Up to 70% of the distance runners will sustain at least one injury during any year period. That's up to. I've seen that as low as 30%, but 30 to 70, that's quite a bit, all right? 80% of the running-related injuries occur at or below the knee, which is interesting. So, a study of 2,000 runners showed that 50% of the injuries were at the knee. We'll cover what kinds of injuries those were. 40% of the injuries were at the foot, ankle, and lower leg. And then less than 20% of the injuries occur above the knee, okay? Now, here's what I want you to remember. If you remember nothing else, okay? The foot bone is connected to the leg bone. The leg bone is connected to the thigh bone, and the thigh bone is connected to the pelvis bone, okay? It's all one thing, and it's working together. We get so narrowed in our focus, whether it's in orthopedics or sports medicine on, it's a knee. Well, last time I checked, below it was a foot, and above it was a hip, okay? So we got to tie that in. And if you're not tying that in to either your prevention strategy or a recovery strategy from an injury, you're missing the boat, okay? Knee injuries, most common, patellofemoral pain. That's generalized anterior kneecap pain, okay? Also called chondromalacia, patellar tracking syndrome, anterior knee pain. The concept is your kneecap sits on a track, on a groove of the thigh bone. And so very oftentimes it's explained that that kneecap, like the train on the tracks, is getting pulled to one side or the other, and the underside of the kneecap is then rubbing, okay? And so for many years, and even I think to this day, a lot of sports medicine orthopedic people talk about trying to control that train on the tracks, okay? There's one problem, that's only 50% of the story. What if the track is moving under the train, okay? So we got to have control of that thigh bone for your kneecap to rest and stay in that track well. All right, IT band syndrome or IT band friction syndrome. This picture doesn't quite show it. This is a right knee. Here's the kneecap, and normally they've taken it off so you can see the anatomical features. But there's an IT band that's coming all the way from your hip, where it starts as a muscle, and then connecting across the side of your knee. And as you bend and straighten your knee, bend and straighten your knee, sometimes that can start rubbing. Okay. Another interesting anatomical thing, 60% of your gluteus maximus fibers blend into your IT band. So if you don't think that your hip is connected to your knee, there's another one, okay? Not as often, but cartilage injuries in runners can occur, okay? And then patellar tendonitis, the tendon that runs from your kneecap just down to your shin bone. Ankle, foot, lower leg injuries, Dr. Hecker will cover a little bit of this, but Very common plantar fasciitis, the Achilles tendonitis or tendinosis. The two are different, okay? Medial tibial stress syndrome, this is what most of you know as shin splints, okay? Then there's stress reactions, which is bone starting to break down a little bit, which then can lead to a stress fracture, okay? Certainly a lot of others, tendon overuse injuries, we'll see a variety of those different ones. Heel pain that's not plantar fasciitis, other things. Other common ones, hamstring overuse, okay? Big difference if you have a middle of your belly of the muscle, mid-thigh injury from the attachment right on your sit bone. You got to treat them different, okay? What do you suppose if somebody had a tight, sore hamstring, what's the most common advice they're going to be given? It's tight and it's sore.
Stretch it.
Stretch it, okay? That's, in our world now, that's becoming a little bit old school. We got to ask one question first. Why is it tight? Typically it's not tight because it's underworking. Tight maybe because it's overworking. If we can go and find who's the slacker out of the group and get those muscles working, the hamstring suddenly can feel much better, okay? Hip tendonitis, bursitis, tends to be more on the outside of the hip or in the side of the hip muscles. Lower back pain. Lower back pain is not just lower back pain. You got to differentiate, is that coming from my spine, meaning my vertebral column and the joints and discs, or is it coming from one of the sacroiliac joints or SI joints, which each of you have two of those. Those are the little knobs right on the back side of your pelvis. Hip impingement tends to be pain in the front of the hip or groin, okay? And then of course there's isolated muscle overuse where a muscle's just getting taxed way beyond its normal allowance. Here's a study of 2009, suspected mechanisms and the cause of overuse running injuries. This was just a clinical review where these people went and looked at 70 research articles to kind of see what the trend was. What are we seeing? What are people studying with the research? The results of these studies, which again are isolated, the majority of the risk factors researched over the past few years can be generally categorized into two groups. Atypical foot pronation. Does everybody know what foot pronation and supination are? Okay. Pronation being more flattening of the foot. Okay. Supination being the arch coming up or the foot becoming more rigid. Okay. How many of you would say pronation is bad? Good. Very few. You got to pronate and you got to supinate. And it's important when you do it and how long you stay in each phase. Okay. The conclusion, I love the conclusions of these studies because the first thing I always put is more research is necessary to, determine anything, okay? There was no definitive link between atypical foot mechanics and running injury mechanisms. Well, how many different types of foot types do you think there are? And what's a normal? I don't think there is a normal. So that's the next comment. Lack of normative data and a definition of atypical foot is hampering progress. Okay? But this was interesting. A large and growing body of literature suggests that weakness in hip stabilizing muscles leads to atypical mechanics and increased forces within the lower extremity while running. Okay, and we'll cover that. All right, here's another study done by Kendall. They looked at 60 runners that had patellofemoral pain, so they all had knee pain, and they looked at 52 runners that had no pain. 90% of the runners with pain exhibited significantly reduced hip strength. Hip external rotators, abductors, and hip flexors were the main culprits. This obviously suggests there's a relationship among hip weakness, side-to-side strength, symmetrical or not, and overuse injuries. All right, so let's go to prevention. From those of us who both treat the injuries but also like to prevent them, what are we looking for? Okay, you got to understand that running is no different than walking, and it's no different than crawling. When it's done efficiently, there has to be a reciprocating motion, just like when you watch a little baby crawl. Okay? We test for range of motion. Range of motion is an indicator. Just because it's tight doesn't mean I want to stretch it, but I may. Okay? We're looking at muscle firing patterns. Okay? The term we use is neuro, meaning the neurologic system, proprioceptive testing. We're looking to see if your nervous system can go out on the grid and correctly communicate with a muscle. Okay? Remember, when you're running, you don't get the chance to get stability when on 2 feet. That whole game is played on 1 foot at a time. Okay? So we test for that. Now, just because I have a muscle working well for 10 reps of an exercise on the table or in the gym does not mean that it has functional stability when I'm out on a trail run or I'm 9 miles in. Okay? That muscle might start to give up a little bit. Certainly gait analysis. How do you move? Okay? What's your running gait? What's your walking gait? Those are all clues. Okay? The strength endurance, we call it the run test. Okay? A number of years back I was testing a lot of endurance athletes, and they would come into the clinic and they would pass every one of my tests, yet they still had pain. And I could not for the life of me figure out, well, where am I going to go with this? I don't have any indicators in what I'm going to treat. Okay? Then it hit me. Well, the swimmer is swimming for an hour and 45 minutes to 2.5 hours. I wonder what would happen if I took my table to the pool, tested them before the workout, and then tested them an hour and a half into the workout. And guess what? That's when everything showed up. So with runners, a lot of times what we'll do is we'll have them come into the clinic hour and a half before their appointment. For a biker, I had him come in 3 hours, and we had to send him and ride up over Horsetooth and up to Carter Lake and everything. And then we got to see what happens, because then when your system is under duress or stress, that's when we really see some things. Okay? All right, any questions on that? So, ready, set, go. Screening. About 7 years ago, I had a little epiphany. I was taking my daughter in for a sports physical. She was going to join the local club swim team, and she had to have a physical. And so we went in for this physical, and most of you know what that's about. We're trying to check their eyes, you know, check their heart, check their lungs, make sure there's nothing major. And at the end of this exam, which was done just like a good standard exam, the doctor said to my daughter, well, what sport are you going to do? And she said, well, I'm going to be a swimmer. And he said, well, that's great. Can you put your arms above your head? And she went like this, and he goes, does that hurt? She goes, nope. And he said, have a great swim year. And I got to thinking, you know, with our kids now, I mean, they're going big time on these sports. It isn't just a little, you know, 6-week program. It's a lot of year-round stuff. Who's checking this stuff for the overuse injuries out of the kids? And I got to thinking the answer is nobody, okay, until they're hurt. So the idea was to make it sports-specific and also make it athlete-specific. So we now do that Ready, Set, Go program with gymnastics, swimmers, baseball players, 3 of the CSU teams, and you'd be shocked at what you find when somebody isn't in pain. And you kind of have that aha and kind of go, I'm a little worried about your knee. We just had a soccer girl in last year. Her 2 older sisters had both had ACL tears. Not once, twice. And that daughter was next. Luckily we caught it, and I think she's doing great. But that's the idea behind, you know, screening for that stuff. Prevention 101. Obviously you guys need to be wise about your mileage and intensity. That if you violate that rule, it's hard to stay out of trouble. Okay? Certainly training surfaces, trail running, concrete, sloped roads, those things will always come in and be part of the picture as well. Shoes, there's a huge one. Or no shoes, the people that aren't running in shoes anymore. Biomechanics, that's our world. How are the joints working together? How is the coordination of muscle firing patterns? Okay? And then obviously we could always improve form efficiency. Form efficiency can change when you're running 3 miles versus 12. Okay? Testing. Kelsey, could you grab the lights? Who said there would be a guinea pig here? Okay, come on up. And guys, fire away with any questions. All right, have a seat right here, facing out toward these guys. All right, I don't want to know what's wrong. Let's just kind of see what your body shows us, okay? So when we look at from her pelvis down, okay, there are some features about our general anatomy that becomes very revealing, okay? Here we got a hinge joint, predominantly a hinge joint, okay? Down at the foot we got another hinge joint, but we've also got movement in 3 different planes. So there's some rotational transverse motion, okay? Then up here we got a hip joint, which is a ball and socket joint, which is excellent for rotation.